Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 134. This will be about the ECTRIMS lecture, Cognitive Function in Multiple Sclerosis, Progress and Perspective, which was given by Professor Pia Amato. She is Professor of Neurology at the University of Florence, Neurofarba Department in the province of Florence, Tuscany, Italy. And she was starting with trends that are happening. So that we are living in an area of early, highly effective treatments in MS, where we get an earlier diagnosis, where we can start earlier with treatment with highly effective DMTs, which causes a dramatic reduction of clinical relapses and, of course, a delayed disability progression. But unfortunately, there's still that silent progression, or PIRA, so the progression independent of relapse activity. And we have already improved long-term outcomes, but of course we want to even have more of it when we can address the PIRA. So she was starting with the findings from the global PROM survey, so the patient-reported outcomes in MS survey. And they were asking for symptoms that matter to patients, and the symptoms most commonly experienced by respondents in the past 4 weeks are some you are probably not very surprised by. Number 1, fatigue, 86%. Number 2, stress with 80%. Number 3, pain with 75%. Then same ranking, problems in concentrating, also 75%, and memory problems, 74%. And just to get an idea, 69% of the people responding to this survey had a relapsing disease course. 12% were defined as secondary progressive, 9% as primary progressive, and a small portion with unknown disease stage. And she was going into 5 topics, and I will do the same. But just to give you an outline, so she was talking about cognitive impairment across the MS continuum, insights into physiopathological mechanisms, cognitive phenotyping, a glimpse into management approaches, and future directions. But so let's start with the cognition. Cognition enters MS research since the late 20th century. By then, neuropsychology was established as a recognized discipline. There was collaboration between neurologists and neuropsychologists, and an appropriate neuropsychological batteries were developed. And if I remember correctly, in the 1970s, the MRI started, and it started to become more available for neurologists, and this, of course, helped a lot. So there was some pioneering research, and Pia Amato pointed out that there were first very good papers on cognitive dysfunction and multiple sclerosis in 1991, by Stephen M. Rao, and another one on correlation of magnetic resonance imaging with neuropsychological testing in multiple sclerosis, I think it's even 1989. So people started to look into that topic, and they defined a frequency and cognitive profile with a prevalence figures of 30 to 65%. So people realized there are issues. And these 6 main areas were complex attention, so problems with sustained attention, divided attention, selective attention, and especially processing speed. Another domain was learning and memory, so free recall, cued recall, recognition memory, semantic and autobiographical Very important here is the long-term memory and implicit learning. Then there is the section of social cognition, recognition of emotions. The theory of mind is here something she pointed out, and insight. Another area, executive function, planning, decision-making. Here, very important for MS is working memory, but there's also responding to feedback, inhibition, and flexibility. Then there is the fifth area is language, so object naming, word finding, fluency. This is something very important for MS, and I think many of you have had issues with that already, or at least know people with MS who have issues with that. Grammar and syntax and receptive language. And the sixth one is perceptual motor function, so visual perception, visuo-constructional reasoning, and perceptual motor coordination. And sorry for all that research, but I think it's quite interesting. So at least I want to give you quite an overview. And when we are talking about cognitive impairment across the MS subtypes, it starts already in CIS. So when we are not having a clearly defined MS diagnosis, so CIS, if you remember, it's clinical isolated syndrome. It's kind of a prodrome status of MS. So when there is already disease activity, but people are not fulfilling the McDonald criteria, which are needed for a diagnosis, then 45% of those having a relapsing remitting course have problems. 79% with secondary progressive, 79%, sorry, and 91% with primary progressive. And overall patients it is 46%. So nearly half of all patients, and the number was 1,040, experiences cognitive impairment. And this setting was a multi-center, clinically based one, cross-sectional study where they said, okay, cognitive impairment is defined as impairment in at least 2 cognitive domains. So if you have just one, this was not counted. It had to be 2 of them. And even in the radiologically isolated syndrome, so it means there are changes in the MRI, but you can't feel anything. There is already cognitive changes found in 24% of people with an accidentally RIS diagnosis. And this is also associated with decreased total brain and cortical volumes, which can be measured by MRI. Then Pia Amato pointed out that there is also quite some research happening in pediatric MS, so when kids or youngsters are diagnosed with MS. And here the numbers vary a little bit, but there are different studies from 2005 until 2023. And the numbers are between 35%, and the lowest number in CIS is 18%, but with a MS diagnosis for sure, the lowest number is 22%. So 1/5 of pediatric patients already have cognitive impairment. Then there was another study done by Emilio Portaccio on long-term outcome and functional impact. And so work and social attainment scale. So when these kids or youngsters have MS, this has kind of an influence on their work and social attainment in adulthood. So there's a negative impact on the socioeconomic outcomes associated with pediatric onset in MS. So the positive side is that 80% of pediatric MS patients were either stable or improved when they had relapses and activity on MRI, or visible, or not visible but tangible. But nearly 20%, 19.7% declined versus 5.1% of the control group. So unfortunately for some of them, this has some effect. Then Pia Amato was pointing out that aging with MS, of course, brings some interaction. So everybody, even healthy people, when they age, they experience cognitive decline. But with MS, this can have additional effects. So there is an overlap of the aging cognitive problems with the MS cognitive problems. and this drives cognitive impairment. And it feels like that the brain of us people living with MS appears older than expected. Of course, this is always on average, but we should really look into that topic. And I'm glad she was giving that lecture because normally more or less everybody tries to be part of the lecture session. So 9,000 people listening to it, this will have effect on clinical trials. This will have effect on people going to their regular tests, and that there will be hopefully more screening on cognitive issues. So how can cognitive impairment progress in MS? There is, of course, an isolated cognitive relapse that can happen or not. Of course, there is one. They found that out. And this can happen even without any other new symptoms. So you don't have any issues with walking. You don't have any issues with your bladder. You just have issues with your cognition. And that is something important. I think that is kind of new to lots of people, and I guess as well to our MS community. And this can have an effect on the SDMT, so the single-digit modality test you are probably doing every now and then when you are going to your neurologist, that there is a decline and then recovery curves in patients with cognitive relapses. And there was even a study by Tom Fuchs on cognitive PIRA or PIRMA. So PIRA again is progression independent of relapse activity, and PIRMA would be progression independent of relapse activity and MRI activity. And when they did a retrospective analysis, so they were looking back, and checked on data that was existing of 336 patients with relapsing remitting MS. They were looking for different kind of tests, and they found out that there is a cognitive decline in 68% of people independent of EDSS worsening. So that is really interesting, and I think quite some of you, dear listeners, had the experience that your neurologist said, oh, there's everything fine, we can't see anything, there's nothing in the MRI, so you kind of just feel it, but it's not existing. It could be existing. It could be that you are feeling the right thing, and research and, let's say, all the experts who are joining ECTRIMS and other conferences realize now there can be cognitive decline independent of a EDSS worsening. So the EDSS, just to remember, that is the normal neurological testing. Yeah. And there was no acute disease activity in 80%. So only nearly 20%, 19.6% had an acute disease activity. I think this is really interesting. So yeah, we should do cognitive screening and monitoring in MS care. This is getting there's some rising education and awareness in that. And it is important for adults and children who are 8 years or older. And at a minimum, there should be an early baseline screening with a simple digit modality test, so the SDMT, or a similarly validated test when the patient is clinically stable. There should be an annual reassessment with the same instrument or more often as needed. And of course, it's here again, it is key. Standardization is important. If you always change the tests, you can't compare them. So if you do SDMT, you should do it again and again. And if you do other tests who are valuable, then you should do these over and over. For adults 18 years plus, comprehensive cognitive screening for those who test positive or demonstrate significant cognitive decline. This is important. And Pia Amato was giving some insights of other test batteries, and they were used by Stephen M. Rao, Dawn Langton, and Ralph H.B. Benedict. And these are the BRB, so the Brief Repeatable Battery, the BICAMS, which is meant for Brief Cognitive Assessment in MS, and the MACFIMS, so the Minimal Assessment of Cognitive Functions in MS. Yeah, and there is already a new joint ECTRIMS IMS-COX guideline project with the aim to develop a guideline to assist the identification of cognitive impairment among adult people with MS according to currently available evidence. It is there to structure the guidelines so that they can be suitable used in both clinical and research application. And in this expert panel, there are 55 multidisciplinary experts involved from 27 countries, so hopefully from yours as well. And there are also people with MS and association panels. So I think this is a very great opportunity to improve the outcome, the research, the normal daily routine for us people with MS. So we are moving on to number 2 of her given talk, insights into physiopathological mechanisms. So there is a multifactorial mechanism underlying the cognitive impairment in MS. And this is going a bit too much into details, but just to give you an idea, there is damage to the normal appearing white matter. So in the brain, we have white matter and gray matter. There is focal white matter lesions. This is the one we normally can experience as relapse, not all of them, but we can see them quite easily in the MRI. There is gray matter damage and atrophy. This is not so easy to be seen in the MRI. And then there is functional network dysfunction, not easy to be seen in the MRI. And this is very important for the cognitive aspects, for the cognitive decline. And then she was showing a picture with the brain reserve when it's at the beginning high. Of course, that helps compared to a low one. And when you are being very active and try to improve your cognitive reserve, this can help as well to have a positive mechanism that works against this decline. Then she was talking about cortical atrophy and lesions. And the more we know about it, the better we will be able in the future to have really personalized medicine. So not all of us will have issues with cortical lesions, which are very much contributing to the cognitive decline. But there might be neocortical atrophy already present in early relapsing remitting MS with mild cognitive impairment. That was found by Amato and Di Stefano in 2004. And there are some people who are stable and improving, and there are some people who are worsening. And in the future, with new medications on the horizon, it will be important to find out who needs which medication. So there are strategic brain hubs, and when these are affected, this is a bigger problem. So again, it's important to find out who has these issues and to get then the right medication. And she also pointed out some papers by Stefano Ciccardi and Massimiliano Calabrese that early gray matter atrophy predicts long-term cognitive impairment. So people who don't have issues in the gray matter, they are way better off than people who have issues there, and we need to find them out. And they did a research with 175 people with MS, followed up for 20 years. And they found out that early gray matter volume loss of specific cortical and deep gray matter region predicts global and domain-specific cognitive alterations after 20 years from MS onset. So there might be memory impairment, attention and processing speed impairment, and executive functioning impairment. And this is all caused by this cortical and subcortical atrophy in certain regions. I think I don't need to mention them. It's a little bit too much of research. Then, which is really, really great, there are emerging imaging markers. So cognitive changes in patients with relapse-free MS treated with high-efficacy therapies might have predictive value of paramagnetic rim lesions. And these rim lesions are important because they show there is something going on. And there's another one, chronic active lesions and larger choroid plexus explain cognition and fatigue in multiple sclerosis. And when we check them out, we see that there are issues and we can again decide on the right treatment. So then she was explaining from regions to networks, task-related functional MRI. This is a very specific type of MRI, which is not done in a normal setting. It is only done in research as of now. And there are controls where people can check, and the work was done by Catarina Mainero and Iris Catarina Penna. Alertness task, incompatibility task, and working memory task. And there are people with which are mildly impaired, severely impaired, and of course people who are not impaired. But these three sections are important. And we need longitudinal studies there. So looking for many, many, many years to find out which are the worst scenarios. And there are some people doing great work there, but I think, again, this goes too much into the details. So now we are coming to a point which is important, and that is cognitive reserve, a more efficient brain network. So about cognitive reserve, I was talking, I think, quite a lot already, that we need to train our brain and live a brain-healthy lifestyle. And they really found out that intellectual enrichment protects us people with MS from cognitive impairment. And that is something I try to do. I mean, I was doing now the master studies program. I'm doing the UPATI. I'm reading a lot. I'm trying to socially interconnect with other people. And this is all something that is helpful. And you should try to do the same as much as possible, of course, always depending on your life. Yeah, then they were talking about synapses. I think this goes a little bit too much into details. I will jump over this. I think this is important for the neurologist, but not so much for us. So we are coming to topic number 3, cognitive phenotyping. And this is something very important. There was some work done by Ermelinda De Meo, identifying cognitive phenotypes, and she was checking in her research 1,212 MS patients with some definitions, so 196 age, sex, and educational matched healthy controls. And they did an assessment. They did the Rayos battery, strobe test. Yeah, I think I don't need to mention them. So they were checking on certain things, and they find there is a phenotype with preserved cognition. 19% belong to it, and I think I'm a lucky one, I belong to it. There are people with mild verbal memory semantic fluency. This is relevant for 30% of MS patients. Then there are people with mild multi-domain issues, 19% again, severe attention and executive issues, 14%, and severe multi-domain, 18%. So when we can find out right at the beginning to which section you will belong, this will be, of course, very helpful, again, to do treatment and to do symptomatic actions. So there was some evidence from other cohorts in identifying and understanding cognitive profiles in multiple sclerosis. And they were checking here on that paper on a role of visuospatial memory function. They had 4 phenotypes, okay. And what are the advantages of cognitive phenotyping? Here we are coming to an interesting point. So we could recognize the cognition as a continuum, which I had the podcast on the new AI structure and phenotyping with AI. Maybe you listen to that one. So we should do the same with the cognition aspect. If we enhance our pathophysiological understanding, we can different neural substrates associated with different cognitive phenotypes, and this can help with optimizing therapeutic strategies, so facilitating the recruitment of homogeneous groups for clinical trials and enabling more targeted interventions. And this is something very important. Now, topic number 4, a glimpse into management approaches. Now we are coming to the practical part of it. So disease-modifying treatments and cognition in relapsing remitting multiple sclerosis. There was a meta-analysis, and they were checking on 44 studies, so randomized clinical trials, the gold standard, on patients with relapsing MS. And before they did that one, it was not clear the effects on the cognitive impairment, which is a key symptom of the disease. So the main outcome was information processing speed, which was checked by SDMT or the PASA test. And the use of DMTs was associated with a small effect size on cognition, which is good, but unfortunately not a huge one. And benefits of DMTs appear to extend to cognition, so that is good. But as mentioned before, so the overall aspect is positive, but still we need to do more. But it has some effect, and that's already a good sign. And the treatment effect on brain atrophy correlates with the treatment effect on cognition, so we can compare that one. For example, when I do my MRI, they always check on my brain atrophy because it's in a research setting. And again, there were 14 trials with 8,813 patients with MS, and they saw that the effect on the brain atrophy and the effect on the cognition correlate with each other. So that is good to know. And the next thing, Pia Amato was talking about the clinical efficacy of cognitive rehabilitation in MS. So there are numerous critical reviews. They have agreed that cognitive rehabilitation offers many benefits to patients. This was a statement by De Luca, Chiaravalotti, and Sandrov in 2020. Reviews on cognitive rehabilitation in MS are increasing a lot. She was giving a diagram where you could see in 2000 there were only a few. And up until 2025, this was raising and raising and raising. So more and more papers and research is coming out on that. And another statement she was giving from Taylor and others was that the evidence suggests that memory rehabilitation results in between-group differences favoring the memory rehabilitation group. Memory rehabilitation is beneficial and meaningful to people with MS. So please, if you have issues, ask for it and do whatever you can on your own in your private life, because this is really important and it will help you. And the rehabilitation-induced neuroplasticity in MS was something else she was talking about. So beyond clinical changes, rehabilitation-induced neuroplasticity MS is there. You can see that brain regions targeted by cognitive rehabilitation have positive effect in association areas in default mode network, regardless of the training type, and in the cerebellum, so especially after retraining of attention. So it helps. You can see that it helps. They could not only prove that MS has a negative effect on cognition, but also prove that rehabilitation has a positive effect on neuroplasticity. And there are evolving approaches. So the traditional approaches was restorative training, compensatory strategies, psychotherapy, and cognitive behavioral therapy, CBT. Then number 2, technologically based approaches, computerized cognitive training, virtual reality, VR therapy, gamification, neurofeedback, and mobile apps and telerehabilitation. And number 3, multi-modal approaches, so combined cognitive and physical training, non-invasive brain stimulation, which is abbreviated with TMS or TDCS, and mindfulness and meditation-based approaches, as well as lifestyle and cognitive reserve interventions. And she was giving some names of people who are very active in that part: John De Luca, Nancy de Chiaravalotti, Brian M. Sandrov, and Anthony Feinstein, who was already my guest and talked about the COGEX study, very important one. I think you should listen to this one if you haven't done so already. Leigh Charvet and Hanneke Holst. And I will try to get all the other people as interview guests on my podcast, because I am always very key on cognition. I think this is very important, and this is something we should all take care of, our cognition. So there is luckily a shifting from reaction to prevention, cognition as a core target, and persons with MS experience cognitive and physical decline despite more effective disease-modifying therapies, and symptomatic treatments currently have limited efficacy. The best treatment of MS disability stays the prevention of decline, so brain maintenance and modifiable risk and protective factors. So if you are a smoker, please stop smoking. Use whatever help you can get to stop smoking. Drink only moderate alcohol or maybe nothing at all, and be as active as possible on cognition, but also on movement. So if you are dancing and singing together, this is also very good for your cognition. Yeah, and then she was giving some chart, premorbid baseline reserve, so reserve depletion. There is an MS disease burden. There are health comorbidities which we should take into account. So if you can avoid comorbidities or have them under control, this helps. Aging is something we can't prevent too much, but if we live an active lifestyle, eat healthy food, so the non-processed food, this helps a lot. As a reserve maintenance, we can do early effective disease-modifying treatments. We can live a brain-healthy lifestyle and diet. We can address risk factors, comorbidities, polypharmacy. So if you take other medications, this should be checked. And on the current potential reserve, negative parts are inefficient use of resources, so poor mood, high stress, non-MS physical demands, e.g. obesity or orthopedic. This will encumber actualization. And on the positive side, maximizing use of resources, prioritizing, restructuring, e.g. minimize dual tasking, cognitive and physical training. And then we end up with a current actualized reserve. So we can do a lot. And future directions. So these are the last slides. Make cognition visible in MS care. And we can do it from our side as patients as well if we ask for it. So it should be integrated into our care with integrated cognitive assessments in routine care. We should leverage digital tools, so innovate monitoring and reduce burden on MS centers. We should uncover mechanisms and biomarkers. I mean, this is something for the researchers and medical doctors. So standardize MRI protocols, use multiparametric imaging, and conduct longitudinal studies. This is on their side. But we should be helpful in taking part in studies and understandings that we should always go to the same MRI. Prioritize cognitive outcomes as co-primary endpoints in clinical trials and real-world studies. Again, this is not on our side, but we can take part. Or if you are a patient advocate, you can help in checking on if it's really happening in the study protocol. And advanced cognitive rehabilitation. Refine evidence-based, tailored, synergistic approaches. And you should ask for it, and you should try what helps you. So I do some neuro playing game in order to be active and stay active. And you can maybe do the same and play with your kids, do cognitive activities, and again, live a brain-healthy lifestyle. And she was giving, again, acknowledgements to the network of Italian MS centers and especially Anthony Feinstein with the COGEX study. Again, please listen to that interview. To Menno M. Schoenheim from the Amsterdam University. Anthony Feinstein, by the way, is at the University of Toronto. And to Cheryl Hemingway, she is at the University College London. And some other associations, so the Sclerosi Multipla Fondazione Italiana, Ministero della Salute, Ministero dell'Università e della Ricerca, Multiple Sclerosis Society of Canada, and ECTRIMS, European Partnership of Personalized Medicine. And by that, I'm at the end. Sorry for being a little bit bumpy, but I was trying to give more or less her lecture speech to you, and hopefully you could take out quite a lot. So let's say, to summarize it, cognition is more and more important. It comes into the main focus of research, into the main focus for clinical trials. We are understanding now that with this high efficacy treatment, there are still some underlying cognitive issues and of course some other issues, but cognition is something that is important for our social interaction, for staying in the job and other things. So it becomes a higher focus because this could lower the burden if we can overcome the issues there. And people are watching for it. There's a lot of things to be done. You can as well ask for better care on that and maybe take care with some apps, with some activities. And with that, a big, big thank you for Maria Pia Amato for giving that very well-rounded up speech on cognition and pointing it out and giving it such an important stage at the beginning of the ECTRIMS Congress. So thank you very much, and I hope I will be able to invite her as an interview guest, but of course she is doing a lot of work. And next time we will have an interview with Dr. Melika Arabafrani, and we will have the topic, let's talk about vaginal health and MS, what women should know. And I think this is very important, as 70% or 75% of us are women. And yeah, so please tune in again. And as always, let other people know about the podcast if they are not aware of it yet. Please rate it wherever you are listening to it, and let me know if you have some questions or suggestions for topics you would like to be listened to. So with that, stay as positive and active as possible, and see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.